I'm going to do the best I can to teach you with this like non-helium-mated balloon pump from Dyersburg, but we'll do what we can. All right, intra-aortic balloon pump, or IABP. So, has anybody ever seen a balloon pump outside of a human body? Yes? I was like, that's not good. I mean, theoretically, if you don't work in the hospital, you shouldn't ever see a balloon pump outside of a human body. But if you want to pass it around just so you can see what it looks like and feel it, all that tubing. I know, it's like, what kind of snacks are in here? All right, so it is a long cylindrical balloon that is inflated. Y'all are distracted by snacks. Okay, that is inflated with helium, and it is typically inserted through the femoral artery, so in one of the groin sites, and then it dwells in the descending thoracic aorta. One thing just to know about balloon pumps, so this is very different from like Impella, is that a balloon pump is sort of considered the lowest on the totem pole of mechanical cardiac circulation or circulatory support. So it kind of goes balloon pump, Impella, VADS, ECMO, right? Or VADS and ECMO kind of together. So balloon pumps cannot restore function that doesn't exist. Once the heart is damaged, all it can do is support the heart. It can help the heart recover from an injury, but it can't really supplement what it already has. So it can only support existing cardiac function. Impella can supplement, this cannot. Does that make sense? Okay. So this is just some sort of background stuff so you understand sort of the function of it. So what does it do? It inflates during diastole. So while the heart is at rest, it inflates. And when it inflates, it pushes blood back into the coronaries. So your coronary, and then I have another slide about that. And it will also increase your mean arterial pressure. So then it will be inflated during diastole. And then when the patient goes into systole, did y'all see it? Okay. It will rapidly deflate at the beginning of systole. And in doing so, it creates essentially a vacuum in their aorta, which makes their afterload very low. So their left ventricle does not have to work as hard to pump blood out. So fundamentally, the idea is to increase cardiac oxygen supply by pushing blood back into the coronaries while decreasing myocardial oxygen demand by increasing how much work the left ventricle has to do. So increasing supply, your coronaries actually, because of they are squeezed during systole, your coronaries perfuse during diastole. So when the heart is at rest is when the coronaries actually get the blood that they need. So by inflating during diastole and pushing blood back into the coronaries, you're increasing your coronary perfusion. This is just a point too, with coronary arteries that are more than 70% occluded, they lose their ability to auto-regulate. So patients who have blockages in their heart, those vessels can no longer dilate and constrict in order to meet their own changes in demand. And then your afterload is the resistance the heart must beat against in order to eject blood. If you create a vacuum in that descending aorta, you are decreasing their afterload and therefore decreasing the amount of work that left ventricle has to do. So again, if you have a patient who has an injured heart, this will help let that heart rest, get some extra oxygen, do some less work for a little while it recovers. This is probably relevant to you. These are sort of anticipated hemodynamic changes when you have a balloon pump that you would expect to happen. So you would expect that their systolic pressure will go down, that their diastolic pressure will go up, so they'll have a slightly narrower pulse pressure. And their mean arterial pressure will also go up. So that displacing of blood will actually help push the blood out as well. Their heart rate will typically go down. Their wedge pressure, which is just their preload, will go down. And overall, they should have an increased cardiac output. And then as a benefit, they should have increased cerebral perfusion, increased urine output, increased peripheral perfusion, and improved respiratory status. So sort of highlights, the major indications are any kind of acute coronary syndrome, surgery, or complications of heart failure. So you're typically going to see this if they're just had a heart attack, you think they're about to have a heart attack, if they just had a PCI, or if they're just having ischemia from some kind of arrhythmia. We often use this in the hospital as like a wean off of bypass. I know that when I worked at a smaller facility, sometimes if we were having a hard time getting them off bypass, sometimes we would take them off bypass, put a balloon pump in, and then ship them out to a bigger facility. So this is something you could definitely see them on this for.
Yeah, see, our small facility is like that. Yeah, they're doing bypass.
Smaller facility. Smaller facility.
We're getting them typically after a cath.
Say that again?
We're getting them typically after a cath that they can't stent and they can't do bypass, so therefore
Yeah.
we're transporting them out. Is that correct? Does that feel like when you're
Yeah, diagnostic cath. You're not supposed to say
Yes,
exploratory.
I'm sorry.
You're not
they
supposed to
can't
say
use stent.
exploratory. They try to find that word.
I mean, I get what you're saying, but like I worked at a hospital in Carbondale and we would still fly people out to St. Louis like all the time. So like there's still like a higher level of care even than places that can do. Maybe some hospitals shouldn't be doing bypass also. And then sometimes as a mechanical bridge to other assist devices like an Impella or a VAD. And then if they are just in cardiogenic shock or refractory LV failure, they can also get this, just again help get them through that whatever is causing them to be in this exacerbation of their heart failure. So I don't know if this matters that much to you, but contraindications are things like aortic regurg. Obviously you don't want to shove a balloon and put extra pressure against an already incompetent valve. Severe peripheral vascular disease, you don't want to put a big balloon if they already aren't getting enough perfusion down to their limbs. If they have an aneurysm or dissection in the aorta, we're not going to put a balloon in it. And then sort of the bottoms of these are sort of more just if they're going to die anyway, we're not going to shove a balloon in them. Okay, so this should be placed with the tip just distal to the left subclavian artery. So this is in your second to third intercostal space. The tip of it is radio opaque, so they will do x-rays when it's placed and then typically daily when they have them in place. And I'm going to tell you how to determine if it's in the right place in the field. But it's going to be just distal to that left subclavian artery. Otherwise, if it's up here, it will obstruct blood flow to that left arm and or to their brain. The base should also be above their renal arteries. If it gets too low, it will occlude blood to their kidneys. That's how you're going to know. So this one I just added because this is really more relevant to you than to anybody I talk to, but securement. So they can be either stitched in. If you were looking at, I don't know if that one has it. Does this one have a place? Yeah. So it has these little wings where it can actually just be stitched into them, or they can have stat locks. Or there are stat locks that are actually specially made for balloon pumps, and they just go right onto those little wing pieces. So you may see these as well. I would say nowadays, Centennial, we pretty much use the stat locks. But you may see them stitched in some places too. So it's just going to be stitched right through here. Also, just one thing to know is that they can sometimes they are inserted with a sheath, but they can be inserted without a sheath. And so the sheath is kind of like what we were talking about before. I think I brought one. But the sheath also, if they use the sheath, has a little hole for stitches also. This is also lubricated and it's gross. I was telling this table up here that I just pulled this balloon pump out of the box and discovered that they come like pre-lubricated and it's real gross. All right, so initial setup. I'm gonna kind of go over, I don't know how much of this y'all need, but we'll go over it. So your power button is right down here.
That's where I'm gonna start.
It's green, has a little power symbol right next to it. One thing you need to do is make sure that the helium tank is open. The helium tank is located right there, where there's a big tank emblem that says HE on it. So this, oh God, I haven't messed with this particular one. The other one at Centennial comes off a lot easier than that. That comes off, this slides out. This piece should be attached to the thing, and you just need to make sure that this tank is open. This tank is empty. That's interesting. Okay, so you need to just make sure it's open and that it's locked in there. So when you take this, you will not be taking this whole cart, but this has to be open in order to fill the internal reservoir of the piece that you take, which I will talk about that in a little bit. But you have to make sure that's open, otherwise you can't get helium into your balloon. Then all that gets closed back up. But theoretically, this should all be set up for you. But if it's not, there you go. Then you're gonna, I have, this is my trainer, but you'll have an ECG cable. Where did I put that? Right in front of my face. So they're gonna have to have double ECG lead pads on, one for your monitor and then one for this. So you'll have pad for your electrodes. And that one goes into there. What else? What's the next step? Fiber optic cable. So there are, I don't know what you're going to see out in some of these facilities, so I just brought the extra ones. Most facilities now use fiber optic balloons. So really the advantage of the fiber optic balloon is that it measures your art line through the fiber optic cable, or it reads your arterial blood pressure through the fiber optic cable, and you don't have to zero it. But some of them come without a fiber optic. So the fiber optic is this piece. So there is a little thing right there. It's got a big orange cable leading into it, and that's where your fiber optic cable goes into. If you don't have a fiber optic cable and you have something like this, I don't have the tube, I don't have the cable for it, but there is a cable right here, and you would just set this up like an art line. So you would attach this. This is an art line piece. You would attach transducer tubing here, like this. I can't turn that right now. And then this part would be connected to your actual thing through this cable that I don't have. Does that make sense?
Yes.
Hopefully you'll have a fiber optic one, but.
No, most of the
Typically,
time we
exactly what you just hooked up.
Okay.
Union City uses that right there, what you're using.
They will not
I've had
open the fiber optic or two.
I've had one fiber optic once out of
Two or three
Jackson.
out of the
Okay.
city with fiber optic, one or two out of Paducah with fiber
Well,
optic.
maybe there's one.
Okay.
Because I've not had a fiber optic.
Well, either way, this piece is just for transducing an art line on either one. It's just whether or not you need to actually attach this to here as opposed to just attaching it to your monitor. Does that make sense? Okay. This one is also pre-lubricated. Gross. And then the only other piece is just making sure you attach this part, which should hopefully stay attached to your balloon pump as well, through here, and this is how you actually attach it to the helium. It does pop out very easily, yes, just so you know. This pops out very easily, and this can also become disconnected pretty easily. But,
You fill that thing up with 6?
huh?
6 fills.
I actually have a slide about the helium filling. So calm down.
I will say for y'all, most of the time if you're transporting, I don't know if y'all do, I take the whole thing to the aircraft. Yeah, I take a perfusionist or somebody with me, and then when I'm ready to load is when I actually take the base out and put it in the aircraft.
Okay.
I've
Because
never-
those batteries are awful. I think Jackson has the battery.
We have
gun
new Jackson.
one
We both
cable.
work off
and
nonsense.
Tyresburg gun.
We have one.
One
Okay.
of each has
We
battery
just got
backup.
one on one.
We all have the battery backup, but
Okay.
it's not the battery, it's more the helium that I stress about.
Well, I have a very specific slide going over how many times you can autofill it.
And it's every 1,000 feet in cycles. Is that right?
I have a slide about it, and you will wait.
Sometimes we gotta guess at this, we ain't actually got a vector
All right, let me just go over some of the higher level stuff about like complications and stuff, and then we'll get into a couple more nitty gritty things about the actual machine. But okay, so complications, things you're going to be watching for. Your most common major complication is going to be vascular complications. So you can have limb ischemia. So this is why you're going to be watching your distal pulses and your capillary refill all the time, because you need to make sure there's adequate blood flow around the balloon and that there's not clotting on the balloon. It can perforate the aorta. Obviously, if that happens, you're just going to try to get them somewhere as quickly as humanly possible. Luckily, that does normally happen with initial placement, not normally somewhere down the line. So normally that would happen before you ever took them out of the facility. Retroperitoneal bleeding, that can happen with any kind of access through a femoral artery, and that's just going to be bleeding into their belly. So if they're suddenly just tanking, the only thing you can really do for that is give them fluids until you can get them to a facility where they can have surgery for that.
We get blood.
Huh?
We get blood.
That's a fluid. And then embolization if they get a clot somewhere around the balloon. So then the other big thing is mechanical complications, the major one of that being a balloon membrane leak. So since I passed it around, you should all have felt sort of how thin that material is, right? So this usually happens when they push that balloon past a calcified plaque in their aorta, and it can cause like a little micro tear in that balloon. So the thing that you are looking at is their extracorporeal tubing. So this is the extracorporeal tubing, this clear stuff. So when you get this patient from somebody in the facility, I would look at that tubing and make sure there is no discoloration in or on that tubing of any kind. And if there is, I would ask the nurse about it. In our facilities, sometimes people go to surgery and they'll get something on it or around it during the initial setup that may cause discoloration to the tubing. But any kind of discoloration to that tubing is considered definitive proof of a balloon rupture, and it's considered like a medical emergency, must be dealt with now kind of thing. So say they got iodine on it during surgery. If you don't know that, and then you're in flight or you're out on the helipad and you look at it and you're like, oh, that looks weird, you don't know that. So I would make sure you get any of that kind of information before you take them anywhere. So what will typically happen if they have a balloon rupture, because of the pressure in that aorta around the balloon, helium typically won't leak out of the balloon, but blood will leak into the balloon. So what you'll normally see is iodine-like discoloration, or you may see like flakes, like coffee grounds, because once the blood gets in there, the helium will dehydrate the blood, so it'll turn kind of like brown and flaky or take on like an iodine type color. And I will talk about that in a second too. It can cause a stroke if it occludes blood flow to their brain. Prolonged immobility can lead to a thrombus formation. It can cause infections. Just be aware that commonly it will cause thrombocytopenia. They don't really know why, but it happens in a lot of patients. And then they can have bleeding in the insertion site. So in order to sort of prevent these and look for all of these, we're going to talk about a couple of assessment things. So their head of their bed shouldn't be greater than 30 degrees, and you should try to immobilize that leg. We normally put knee immobilizers on them in the hospital setting. So they may come with that. You want to do, so these are like how frequently we do things. I don't know how often y'all do checks on your patients. I'm assuming it's more frequently because you only have them for an hour, but we do Q1 neuro checks. That's partially to make sure that they don't have reduced blood flow to their brain. Pulse checks. So I mean, really, you should be doing all their limbs, but you definitely have to do their left arm and both of their legs. That's to make sure they're getting enough blood flow around the balloon down to their legs, and to make sure that the balloon has not migrated up and occluded blood flow to that left arm. So in the hospital, we keep our pulse ox monitor on that left hand. So if you lose your pulse ox, you know that your balloon has migrated up and is now occluding that artery. And then we also check our urine output frequently. Obviously, often they have decreased urine output, etc. But if they have no urine output, it may mean that it's migrated down and it is occluding their renal arteries entirely, and then they're not going to have any urine output, assuming they had any to begin with. But you're going to want to check the insertion site for bleeding or infection. And then again, you want to check that tubing for the presence of blood. Like I said, any discoloration in there is considered definitive proof of a balloon rupture. It is considered a medical emergency, and it needs to be removed now, which is obviously a problem for you when you all are in the air. But I don't know exactly what you would do. In the hospital setting, we are not allowed to remove balloon pumps. It's something a physician has to do. So I'm assuming you would just need to get to a facility as quickly as possible and have it removed. If you do have a balloon rupture, though, you do want to turn the machine off. You don't want it to continue to pump helium into there. You just want to turn it off, take it off, and clamp it. Clamp the helium line. The risk of that happening is that basically a giant clot can form in the balloon, and then it can become entrapped, and then they have to actually have surgery to like pull it out because it becomes just one giant clotted balloon. So that's why it needs to be removed as quickly as humanly possible. So in the facility too, you can't have your balloon not pumping for more than 20 minutes, which I will talk. Yes.
So if there's a rupture?
But you can't pump it if it's ruptured, because it won't do anything. It'll just literally, you'll just be shooting air into them, which would be worse.
If we run out of helium or it malfunctions, that's when we're mainly going to do it. But
Yes.
if your balloon ruptures, you can't do anything. You
Yeah.
just gotta go somewhere fast.
Yep, get somewhere fast, call ahead, make sure they know, make sure they have somebody who can pull it. Because like I said, we don't pull them in the facility. The physicians have to pull them, so they're going to have a physician ready to pull it.
20 minutes?
Okay. All right. So the next thing I'm going to talk about, I'm just going to spend some time talking about balloon pump timing. So if you talk to Getting, they will tell you that their balloon pumps never miss time, ever, because they're magical machines that never make a mistake. This is why I don't have Getting come teach my balloon pump classes anymore. But I would say the majority of the time, balloon pumps are very easy little machines. They do what they're supposed to do for the most part. But I would say that most of the time when I've had nurses come to me and be like, my balloon pump's doing something weird, it's making my patient crump, it's not helping, it's because the timing is wrong. But oftentimes people don't know how to actually check timing. And it's not easy, which is why I actually gave you it says assessment on it because I made it for my nurses to actually take a test. So I'm going to go over it, and if you feel like practicing or whatever, feel free. Or we can go over it if you all actually want to do it. That's up to you. I don't care. So your timing, so your balloon pump is synchronized to the cardiac cycle. This is determined by basically when your balloon pump inflates and when it deflates. And this is determined by your trigger. So your trigger is the event that tells the balloon when the beginning of a cardiac cycle is and to deflate. So the most common trigger is going to be your ECG, and your actual trigger event is the R wave. But you can also use pressure, and you can use pace or spikes if they're 100% paced. So that's an option on here we can talk about. But most of the time, it's going to default to the R wave. So in order to evaluate timing, you have to have your balloon pump in 1 to 2. Does everybody know what that means? So it means it's only going to inflate with every other heartbeat. So you can have it in 1 to 1, 1 to 2, or 1 to 3. So either it will inflate with every heartbeat, every other heartbeat, or every third heartbeat. So we use the 1 to 2 and 1 to 3 settings when we're like weaning them off it also. But you have to have it in 1 to 2 in order to look at timing, because you have to be able to see an regular waveform and then the one with the augmentation wave on it. So the first step in order to be able to look at timing is to identify all of these pieces. So you're looking for your dicrotic notch, which is the closure of your aortic valve. The lowest pressure immediately after your dicrotic notch is your unassisted diastolic pressure. So the balloon pump did not inflate here, so this is an unassisted pressure. The balloon pump is not assisted here. And then this is your unassisted systole. Then as this falls back down, this is when your balloon inflates, and this is your diastolic augmentation wave. So this is the assistance of the balloon pump. So after that are your assisted diastolic pressures and your assisted pressure. So your assisted diastolic pressure and your assisted systole. Clear as mud thus far? Okay. So what you're looking for, the first thing you're going to look for is your inflation. So like I said, right here is where your balloon starts to inflate. So when you look across, your balloon inflation should start at your dicrotic notch. So that's why you have to be able to see this wave without the augmentation on it, so you can see your dicrotic notch. So you see your dicrotic notch, your augmentation wave should start at the same level. And it should form this knife-sharp V shape. And then if your balloon pump's doing what it's supposed to do, your diastolic augmentation should come up higher than your systoles, right? Your diastolic augmentation wave should be the tallest wave. So then you're looking at your deflation. So your deflation is the harder one to look at, just because it should occur just prior to your systolic ejection. But really, when you're looking at your waveform, you're looking at sort of the results of the balloon pump doing what it's supposed to do. So what it's supposed to do is make your assisted end diastolic pressure lower than your unassisted. And it should make your assisted systolic pressure lower than your unassisted. So both of those should go down. So if you look at your unassisted pressures, they're higher than your assisted pressures. Do you see how they both kind of go down? So when you're doing your timing assessment, the first thing you're going to do is look to make sure your diastolic augmentation wave occurs at the same level as your dicrotic notch. Then you're going to make sure that your diastolic augmentation is higher than your systolic pressures. You're going to make sure your assisted end diastolic pressure is lower than your unassisted. And then same with your systole, that your assisted systole is lower than your unassisted systole. And that's correct timing. Timing errors, so there's 4 timing errors. Early or late inflation, early or late deflation. Some of them are worse than others. Some of them are going to cause you more concern. Some of them are just like, oh, it's not going to work as well as you'd like it to. And some of them are actively hurting the patient's heart because they're working against the patient. So early inflation is an example of that latter one, where it's actually working against the patient, because if it's inflating early, it means it's inflating while the heart is still beating, while the heart is still contracting and trying to push blood forward. And now this balloon is inflating and impeding the blood flow. So this one's pretty easy to identify. If your augmentation wave starts before your the level of your dicrotic notch, it is inflating too early. It is supposed to inflate right as the aortic valve is closing, and that means it is inflating while the aortic valve is still open. So this can cause that valve to close early. It will increase the workload of the left side of the heart. It can increase LV wall stress, and it can cause aortic regurg. If it's bad enough, it'll just push that blood right back in the heart, which is not what we want it to be doing. Late inflation is also pretty easy to identify because it will be, your augmentation wave will happen after your dicrotic notch, and you'll get kind of this W shape because you'll have the dicrotic notch and then a dip, and then your augmentation wave begins. This one, not as bad. It just means it's not going to help as much as it should. You're going to have suboptimal augmentation, so your augmentation wave is not going to be as tall. And then you're not going to get that nice push of coronary perfusion back because it's just not going to be inflated when it's supposed to be. So if you could have late or early inflation, you'd rather have late inflation. I mean, you'd rather have correct, but late is better than early. Any questions about those so far? Okay, so then early deflation is when it deflates during diastole. So this one, again, not as big of a deal. It just means it's not going to be helping the heart as much as you would like it to. So you're going to see sort of this sharp drop off of your augmentation wave. And then your assisted end diastolic pressure will not be as low as you would like it to be. And your assisted systolic blood pressure may rise. So this one, again, is harder to identify, but if your assisted pressures and your unassisted pressures are the same, then you have like a deflation issue. So the only problem really with this one is it can actually cause retrograde coronary flow. It will basically suck blood back out of coronaries. Also not great. But it's not as bad as late deflation, so you're going to see this really wide augmentation wave. Your end diastolic pressure is going to come up, and then you're going to have this wide end diastolic augmentation. And so this one is bad because it's going to impede blood flow. You're going to have the balloon inflated when the heart goes into systole. So the heart is going to try to beat against this balloon. So some people like to have sort of hard and fast rules. So this is my attempt to give you some like rules. So if your inflation occurs before your dicrotic notch, you have early inflation. If your inflation occurs after your dicrotic notch, you have late inflation. Your end diastolic pressure should be less than your unassisted end diastolic pressure. So if your assisted is higher or equal, it's late deflation. Your assisted systole should be less than your unassisted systole. If it's not, then you have early deflation. It's like the easiest way to do that. Any questions? Clear as mud? That's why I gave you practice. This is normally something people kind of have to practice and see it before they can really know how to do it. And I realized that I printed the slides with the answers for this one on there. What is that? All right, without looking at your, don't look at your slides. What is this one? I don't know why it says nails in the middle of it. Huh? Is your augmentation wave at the level of your dicrotic notch? Yes, so it's not an inflation problem. Yep, so what does that make it? Oh, I was like, what did I do? Yes, so it's early deflation because your assisted systole and your unassisted systole are the same. Sorry, this little thing is, yeah, so your inflation is correct. Your diastolic pressure is still lower, but your systoles are the same. So that's early deflation. What about this one? This one's easy. You should be able to eyeball this one across the room. Huh? Early inflation, yep. So that is well above the dicrotic notch. What about that one? Yeah, so see how you get that kind of W shape, not that nice sharp V? So I'll give you 3 guesses on this one. But obviously you can see how this gets wider, right? And then see how this is so much higher than this, your end diastolic pressures. I will just give you an aside also, because I had this issue when I did this with a class recently, is that if you have early inflation, sometimes it will look like your deflation is late because this will be wide because it's starting early. But you still need to look at your end diastolic pressures to determine if your deflation is late. I'm just going to say this now, so in case I forget later. If you have, this has the option to operate in auto or semi-auto mode. You can adjust your deflation in auto. You cannot adjust inflation in auto. You have to go into semi-auto. So if your inflation is wrong, you have to go into semi-auto to fix that. But you can adjust deflation in auto mode if you need to. So these are just some asides. Getting will tell you that if your patient's heart rate is sustained at less than 30 or greater than 150, you'll have to use semi-auto mode. It cannot track those on its own. And then you're going to have to adjust your timing. Once you adjust your timing, the pump will then do its thing, right? You don't have to adjust it with every beat, but if you know that it's consistently inflating too early or too late, you have to adjust that, and then it will follow that adjustment moving forward. Sometimes if your patient's very tachycardic, you'll have to go into 1 to 2 mode because it just can't handle doing 1 to 1 if your patient's heart rate's 180. Technically, per the AACN, you're supposed to check your timing whenever you have rhythm changes and if your heart rate changes by greater than 10 beats per minute. If your augmentation is poor, check for signs of malposition, make sure everything's where it's supposed to be. Check your timing, and then beyond that, really you're just going to have to use other treatments to treat your patient's hemodynamics. There's not a whole lot you can do with the pump itself. But I know that on more than one occasion, nurses have been like, it was doing something weird to them, and then nobody knew how to check the timing, and then they found 1 person on the unit who knew how to do it, and it was wrong, and the timing was wrong. And that's why it was causing those issues. Everyone slide. Helium. Okay, so the helium tank, like I mentioned, is located in the bottom of the console. Make sure the tank is open to fill your internal reservoir. So the tank stays on the cart when you take the pump. So this is your little helium indicator. So you want to make sure your internal helium reservoir is full before you take it on transport. If you take the piece off the cart, which one of y'all I'm sure knows how to do that, if the reservoir is not full, you need to put it back on the cart for at least 30 seconds to let it fill. The internal reservoir holds 36 autofills, okay, when full. So it uses 6 autofills every time the pump is turned off, the balloon pump is disconnected, or it has an autofill failure and you have to restart therapy because of any of those things. So if this becomes disconnected, it gets turned off, autofill failure, and you have to restart therapy from scratch, it's going to autofill it 6 times to get it started again. So you want to minimize the amount of times that happens. It will use 1 autofill every 2 hours. It just automatically autofills it. And then to your point, for every 1,000 feet of increased altitude during your ascent, it will use 1 autofill. And then for every 2,000 feet of altitude decrease during your descent, it will use 1 autofill. So theoretically, if you're cruising at 2,000 feet, you're going to use 3 autofills just to get up and down. But you have 36, so assuming you're not having to start and stop therapy a whole bunch of times, you should be okay. But if you have to restart therapy 6 times, you're done. It's gone. Does that make sense? So again, just make sure it's full before you go. You probably should be okay. So you all were talking about your batteries. Just be aware of these I just put these two emblems up there that kind of let you know when you have only 30 minutes or 5 minutes. Obviously you don't want to leave like that. Are you saying you all have the transport power supply piece? Okay. So right here is where your battery bays are, 1 and 2. If you hit these little buttons right here on the front, it will illuminate these little lights on the front that tell you how much battery life they have left. If they have all 5 lights, it's 100%. If they have 1 less light, that's 20% less than, so 4 lights is 80, 3 lights is 60. Ideally, you should have 2 full batteries, or you can put this transport power supply in there. I guess y'all have plugs on the, there you go. So you can plug it in. All right. So, can't actually make this like run for you because there's no helium. There actually is a little bit of helium in there. Like there's a tiny bit. So here, right down here, this does not turn. This is, oh, it only turns that way apparently. Okay. Your icons for your battery and for your helium are right down here. Your ECG should be right here. Why is this not working? Oh, because I unplugged it. That'd be why. There we go. Okay. Couple safety things. Down here at the bottom of your screen is something called preferences. And on preferences, there's display, audio, printer, and pump options. Under audio, there is something called standby advisory tone. You should always check and make sure that is turned on, because that alarm will let you know if you accidentally left this in standby. I don't remember exactly how many minutes it will alert you to, but it will alert you if you, because a lot of alarm states will stop the balloon from pumping and you have to actually manually restart it. Or if you put it in standby and forget about it because your brain has a lot of things going on in it, this will alert you. So it's a really big safety thing to make sure that's always turned on. And then down here is a little thing called aug alarm, and that should be set 10 below your current augmentation value. So if that drops, you know you have a problem. So like I said before, this piece right here on either the fiber optic or the non-fiber optic is the inner lumen. It's basically like an art line. It can be transduced like an art line. If your art line is not transducing anymore, if it's dampened, you want to try to draw blood from this, 3 cc's of blood. If you cannot draw 3 cc's of blood from this, you need to cap it off and use an alternative art line, which, assuming you probably, I don't know if you would have one, but you're not going to have an art line for this anymore. If it does draw blood, then you would just fast flush it and clear it, because this would be attached to art line tubing. But generally speaking, you're not supposed to use this for like blood draws or anything like that.
You're just checking to see if it's, okay.
Like if your art line on here goes bad,
Correct.
like becomes dampened, that's when you would do that. You also need to make sure this is 3 feet above your patient and that you have no more than 8 feet of tubing. What? That's where it's supposed to be.
Maybe 3 inches.
Hang it on the outside. I'm not going to go through like every alarm that this has, but I'll just touch on a couple things. There are 4 levels of alarm. A white alarm is a technical alarm. It means there's like something wrong with the actual console and it's not going to pump anymore and you're just kind of out of luck, and I'll tell you what to do if that happens, but you're not going to be able to use the console anymore. Red alarms are high priority alarms. Yellow is medium, and then they have these little cyan turquoise ones over here. So one of the things you may see is an augmentation below set limit. This could be just because your patient's hemodynamics have changed. And so you're gonna have to treat your patient really more than the balloon pump. That's just really alerting you to like something changing with them. Or you can check your timing. An autofill failure could be because your balloon pump is disconnected, your tank is closed, your tank is empty. So hopefully you don't have that happen because you're going to use 6 autofills to fix it. There is one called balloon pump restriction. If you get this pinched off, which I'm sure is not hard to do in a helicopter, it's going to alarm at you. Just make sure after you relieve it that you hit start again. Otherwise, it's just going to sit there. Gas loss. So if you get this gas loss in balloon pump circuit, the first thing you're going to do is check your extracorporeal tubing for discoloration, because it could be that it's getting lost inside the patient because your balloon is ruptured. So I guess I don't really need to go over this because this is about fiber optic failure, but since you don't normally have fiber optics, you just start from scratch anyway, but you can always attach this to another arterial line also. I didn't really put in slides about sort of like, I don't know if this will actually run or not. Nope, sure won't. Okay. Okay. Do you want me to go over sort of like all of these different menu options? Yes, no?
That would be good for some other people.
Restart it when the hose gets disconnected. That would be nice.
Well, first things first is you're going to reconnect it. And then all you have to do is hit start. Ah, here it is. Okay, so this is what your screen is going to look like. So you have auto mode and semi-auto mode. You should almost always be running it in auto mode. Like I said, the only time you would really go into semi-auto is if you needed to change your timing. And then sometimes maybe if your trigger is being weird, you might need to do that. Calibrate pressure, that you just hold if you need to like zero your line and stuff like that. The fiber optic ones will auto zero for you, but apparently you don't have them. So you will need to push that, hold for 2 seconds. Standby is how you get it to stop pumping. Start is how you get it to start pumping. So just make sure too, if you have any alarm state after you resolve the problem, that you hit start. And also make sure you have that standby advisory tone on. So trigger, your options are ECG, pressure, pacer. You're going to be a real problem, aren't you? We're just going to turn you off so you shut up. Okay. Pacer, pacer V, pacer A, and internal. So I have a slide about this later, but if your patient goes into cardiac arrest and you are doing CPR, you are supposed to switch it to a pressure trigger. Some people just put it in standby. However, that 20 minutes applies to a code also. So if you get your patient back, now you've had a balloon that's been not pumping inside of them and now probably has clots on it, which is not going to be good for your patient. So you're going to want to put it into pressure mode. If your compressions are not sufficient to trigger it with pressure, you can also change it to internal. But pressure is the first option, internal is sort of your second option. Sources, this really just changes like the lead. So like ECG, you can change it from like your 1, 2, 3 lead if you want to. I've never changed these thresholds, but I guess if you need it to be, so pacer detection, like if it's not picking up on your spikes because they're too small, you can turn that up. Balloon pump frequency, this is your 1 to 1, 1 to 2, 1 to 3. Generally, if they have it, you're in 1 to 1. 1 to 2, 1 to 3 are generally used for weaning. 1 to 2 is used for checking your timing. And then again, sometimes you might need to use 1 to 2 if they're very tachycardic. So really the only time I would imagine you would be doing this is if tachycardia, if you wanted to check their timing. Augmentation, this is where you can just turn it up or down how much it's augmenting them. Generally, you just leave that alone and it will kind of auto-regulate for them. And then here's where timing comes in. So this is currently selected on auto mode. So see how this is all grayed out. This is grayed out. This you can still change in auto mode. This you can still change in auto mode, and you can change your deflation. And so on the top screen, which I don't want to turn it back on, but on the top, I wish I had put a picture of this on here. I don't want it to beep at us. but there are little, let me just let it come on. So down here is where you can see inflation and deflation. So right now it's set to auto mode. So right here it says auto over inflation. It won't let me adjust that at all. And then there's a 0.00 over here. So if I went down and changed deflation, if it was on and working, it would actually move this from side to side. So that's how you can tell if it's actually adjusting it. But then you would have to go into semi-auto mode to open up the inflation part. And then the things at the bottom of it are just locking the screen, closing the menu, preferences. Like I said, this has your standby advisory tone on it. It also has, if you wanted to auto print strips for you, how loud you want your alarm to be, stuff like that. Setting your time. IABP fill, that is to actually force an autofill if you wanted to do that, which we do in the facility. If we're about to like change the helium tank, we'll autofill it just so we know that it has fresh helium, because it normally really only exchanges the helium out every 2 hours under normal operating conditions. And then you can freeze your display if you want to, and then unfreeze it. And then printing a strip down here. And then the strips get pumped out through here if there's paper in there.
Be sure there's paper before you leave. Every 5 minutes.
You also should have a Doppler on the back here too.
There's a whole bunch of them. What do you do when you don't have paper and you find that out halfway?
See. You also have a helium tank indicator back here as well. Trying to think if there's anything else on here that you would want to know. All right, so have any of you ever had to manually inflate or deflate the balloon before? Okay, so obviously you're going to want to do, I don't know what I did to that. You're going to want to do everything you can to have to avoid this, but if you get to a point where you cannot troubleshoot the machine and you cannot get it to inflate and deflate the balloon, or you ran out of helium or whatever, the last option is to manually inflate and deflate the balloon. Luckily, you do not have to do this like in time with the cardiac cycle or anything like that. So the reason why I put this sizing guide on here is so that you could hopefully make an educated guess about how big your balloon is, because you're just going to use a 60 cc syringe with a 3-way stopcock on it. You will detach this from its extension tubing. You will attach this, just pop that in there, and you're just going to use room air. You're supposed to use 10 cc's less than the size of the balloon of room air. So this one I think is a 40 cc syringe. So you literally just inflate it with 30 cc's of air. Inflate the balloon, deflate the balloon. You have to do that every 5 minutes. So you don't have to sit there looking at their cardiac cycle trying to figure out when to inflate or deflate, but you just need to keep it moving enough for it not to clot. So every 5 minutes, inflate, deflate. So it is a little bit hard because the different balloons have changed over the years based off of the brand, but they are based off their size. So if they're less than 5 feet, they're either going to have a 25 cc or a 30 cc. 5 feet to 5'4" is a 40 or 34. So make an educated guess. Just don't overinflate it and bust the balloon, I think is the most important part. So you do want to make sure you have a 60 cc syringe with you and a 3-way stopcock. And I think that this can be a little bit confusing, but yeah, this part just pops in here. And that's how you do it. Every 5 minutes. If you can't restore pumping within 15 minutes. 5'4" and taller is 50 cc's in the big one, but it's only 40 cc's in these ones. So 30. So you can troubleshoot it for about 15 minutes. So yes, it can be in standby for 20 minutes, but if you can't figure it out by 15 minutes, I would start doing that. I already kind of talked about this. If your balloon patient goes into cardiac arrest, your balloon pump should be turned to a pressure trigger. If the pressure trigger is not enough to actually trigger the balloon pump, change to an internal trigger, and you want to turn your augmentation down to 50%. I don't know why, that's just what they say you're supposed to do. You can defibrillate them, just make sure nobody's touching the balloon pump. And again, the pump not being in standby for longer than 20 minutes applies even in a code.
So we're not gonna, no.
In case of accidental removal, this is the same slide basically as the art line. I think it'd be quite a feat if you got this whole dang thing out of them, but because that's a lot. That's a lot to pull out of a person. But again, just remember, for removal of any kind of sheath in a femoral artery, your insertion into the artery is going to be higher than your insertion into the skin, so make sure you're holding pressure above where it goes into the skin. Otherwise, you're going to end up with a big fat hematoma under their skin that's going to be pushing on their femoral artery. And that is it. That is all I have.